So, sir, we are starting for today.
Yes, sure.
So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as the digital partner for this online event called Neonatal Pathshala series hosted by the National Neonatology Forum Gujarat chapter. The focus of today's session is case presentations on neonatal seizures. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Iyer, sir, the Honorable Secretary of NNF Gujarat chapter, to start the event today with his enlightening words and for the further coordination. So the dais is all yours, sir. Please proceed.
Thank you so much, Ritu. So, with great pleasure, we'll like to continue with our Neonatal Pathshala series, which we do it on every Wednesday. So today we are conducting a case presentation, which we do on one of the Wednesdays every month. So today we are having an interesting case on neonatal seizures. To present that, we have Dr. Vinita Savlani. She has done her MBBS from BJ Medical College, Pune, and DNB from Jupiter Hospital, Thane. She is currently working as neonatal fellow at Anand Children Hospital. So today she is doing a case presentation under the mentorship of Dr. Sachin Shah, who is a renowned neonatologist and having a wide experience in neonatal practice at Anand Children Hospital, Surat. I welcome Vinita and Dr. Sachin. So today we have two experts. One is Dr. Sridhar Joshi. He is an DM pediatric neurologist. He's presently working as assistant professor at CMC, that is Christian Medical College, Vellore, since September 2022. Sir has done a DM in pediatric neurology from the same institute, that is Christian Medical College, CMC Vellore, and he is the first batch to graduate under the National Medical Council led DM course. Sir has also done his MD Pediatrics from Lady Harding Hospital and MBBS from Baroda. So I welcome you, Dr. Sridhar, sir. Next, we are having an expert, Dr. Sandeep Tilwani, who is a DM neonatologist, is presently working as assistant professor in neonatal division at Department of Pediatric, GIMS, Bhuj. He has done various publications, and his special area of interest is neonatal infection, neonatal nutrition, and neonatal neurology. Welcome, Dr. Sandeep Tilwani. So without wasting any further, we'd like to start the session, for which I would request Dr. Vinita. Before that, Dr. Vishal, are you there? I think is
Yes, 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 yes.
yeah. So sorry, you are in an emergency, I know that, but if you like to say a few words, then we can start with our case presentation.
Yeah, first of all, I would like to thanks Sheila madam to to advise to invite the two experts from Gujarat, and again, and also Dr. Sachin Shah sir to allow Vinita to present the case in NNF Pathshala. And I think we can start the session. I think there's no and not any issue. And both expert, you can interrupt if you have any question in between that one. So I think we can go ahead, Kunal.
Yeah, thank you so much. So Vinita, you can share your screen now.
Yeah. Am I audible?
Yes.
And the screen is visible. So, should I start?
Yeah, sure.
Okay, good afternoon, everyone. Today I'll be presenting a case of a 10-day-old female neonate who presented to us with complaints of seizures since the 8th day of life. So, I would like to start with the antenatal and birth history. The mother was a 27-year-old G2A1 mother who was registered and immunized. It was a non consanguineous marriage, and the mother did not have any comorbidities during pregnancy. The baby, a female neonate, was born by full term LSCS due to a single loop of nuchal cord, and the baby cried immediately at birth. The birth weight was 3 kg, and the baby did not require any resuscitation at birth. And the baby was discharged home after 3 days of birth. So till now, the baby did not have any complaints or any issues at all. So the baby started seizures on the 8th day of life. Actually, the baby was admitted at another hospital previously. So over there, they sent preliminary investigations like blood sugar, serum electrolytes, calcium, and they also did a sepsis screen, all of which were within normal limits. And the seizures, the kind of seizure was not mentioned, or nor was there video evidence. But the baby over there required phenobarbital, levetiracetam, and phenytoin for the seizures to be controlled. Further investigations were done, USG brain and CSF studies, which were both normal, and the baby was shifted to our setup after 2 days for further management. So, on admission at our setup, the baby had a tonic convulsion, which was observed by two neonatologists. It involved all four limbs and it was associated with tachycardia. There were no associated eye movements or any other facial movements, and the seizure lasted for around 40 to 45 seconds. The basic investigations on admission and during the seizure, we did a blood sugar, which was normal. We did a blood gas and electrolytes again, which were normal. A sepsis screen and a blood culture was sent, and the baby was started on antibiotics. And the baby was continued on phenobarbital and levetiracetam. Negative history. The mother did not have any history of fever during pregnancy during any trimester. There was no history of any increased or decreased fetal movement. There is no history of drug intake. There was no history of any prelactal feeds given to the baby. And there is no history of feeding or breathing difficulty up until the presentation of seizures. And there is no family history of seizures. On examination, the baby was vitally stable on room air. The anterior fontanelle was 3 by 4 centimeter and the head circumference was 34 centimeter, which is around the 50th centile for age. There were no abnormal faces. Eyes and ears did not have any anomalies, nor were there any other external anomalies. The baby did not have any neurocutaneous markers. Respiratory, cardiovascular, and per abdominal examination were within normal limits. Uh, on presentation, the baby was stuporous. The cranial nerve examination, once the baby gained consciousness, were within normal limits. On motor examination, passive and active tone were normal. The deep tendon reflexes were mildly diminished. In the neonatal reflexes, the Moro's reflex was incomplete. Tonic neck reflex could not be elicited. The palmar grasp was weak, and sucking and rooting reflexes were poor. We did an EEG for the baby 1 day after presentation, which was normal. The baby continued to have a reduced activity and poor suck, so we sent phenobarbital levels, and the drug was withheld. The level of the drug was in the toxic level, hence phenobarbital was discontinued. The baby was observed for another 2 days, and the baby improved clinically and was accepting oral feeds well, did not have any clinical seizures, and the EEG was normal, and the baby's neurological state and reflexes normalized. So the baby was discharged on day of life 15 on monotherapy with levetiracetam at 45 mg per kg per day. Then on day of life 21, the baby presented with seizures of similar semiology, which are tonic in nature. There was a history of reduced feeding for the last 24 hours. On admission, the baby had to be reloaded with phenobarbital, levetiracetam, and phenytoin in that order, and required ventilatory support in view of status epilepticus. And in spite of being loaded with the three drugs, the baby continued to have status epilepticus, hence was clinically, and hence he was started on midazolam infusion. State in between intermittent, the baby still had tonic and even intermittent clonic posturing. So topiramate was started, and pyridoxine and biotin were also started suspecting an IEM after sending a metabolic screen. Course in the NICU, midazolam infusion was stopped after 48 hours as seizure control was obtained, and the baby was taken off respiratory support after 3 days. Uh, the baby was seizure free on the anticonvulsants. We did not have to add on to any more. And uh, then the investigations we sent were showed a positive sepsis screen, and the culture showed Enterobacter. Antibiotics were administered according to the culture sensitivity report. CSF studies were also done, which were normal. We had sent a metabolic screening by tandem mass spectrometry, which also turned out to be normal. And we also did an MRI brain, which was normal. And currently at this point, the baby was seizure free. Pyridoxine and biotin was stopped on day of life 28 as the metabolic screening was normal, and the baby was being planned for a discharge in view of well-controlled seizures and a completed course of antibiotics for the sepsis. On day of life 38, the baby had an episode of fever followed by a breakthrough seizure. There was a preictal rhythmic high-pitched cry with perioral and ocular twitching, followed by a myoclonic seizure, and it lasted for a few seconds and was repeat over a period of 1 hour. There were 4 to 5 episodes of this seizure. Uh, the anti-seizure medications, which are ongoing in oral doses, were shifted to intravenous doses. And we repeated an EEG 1 day after the breakthrough seizure, which showed epileptiform encephalopathy with burst suppression. Pyridoxine and biotin were restarted. We sent a genetic testing for the baby because none of the other all of the other causes were ruled out. And the baby was discharged home once was seizure free for 3 days on the ongoing medications, and was discharged home on phenobarbital, phenytoin, levetiracetam, topiramate, and pyridoxine.
Hello, Dr. Vinita.
Yes, sir.
Yeah, I had a few questions.
Yes, sir.
Do you have any video of EEG or anything like that? Have you taken any snapshot or video of EEG, MRI, anything?
Uh, no, sir. I don't have that with me current.
Seizure video?
Sir, sir, there is one video which was when the baby was readmitted with us at 21 days of life. Just a minute, sir. I'll show that.
Yeah, meanwhile you load the video. Few questions, please answer me. What is the significance of increased fetal movements? You ask in your antenatal history, negative history. You ask regarding increased or decreased fetal movements. What is the significance of increased fetal movements, and why did you ask that question?
So some channelopathies can present with fetal seizures in utero. So that is why I asked for the question of increased fetal movements. And
Channelopathy.
uh, so there are two the channel mutations can present in utero. One of one of them.
Yeah, any neonatal seizure which are channelopathies or non-channelopathies like metabolic etiologies like pyridoxine dependent epilepsy or pyridoxal 5-phosphate dependent epilepsy, all of them can have intrauterine or fetal seizures. That's why we ask for increased fetal movements, which is fetal hyperkinesia. So how do you tell it clinically? What is normal fetal movement? When do you call it increased? When do you call it decreased?
Uh, so they use the Cardiff count of 10. So basically, a mother is asked to count for fetal movements at the same time every day. Generally, it is asked to do it after food, and the mother is asked to count till she feels 10 fetal movements and how much time it is. And the other way is once in an hour, how many fetal movements are being recorded, are being felt. That is how. And objectively, we can see it using cardiotocography, uh, biophysical profile.
Yeah. So basically, the count is one thing, which is 10 in a thing, 10 in a moment. But what clinically will mother will tell is like she can feel like he's continuously kicking around. Like even if she is able to, she is holding the baby or calming down, or even before feeds, continuously he's kicking around, and you get multi-quadrant kicks. Like you get kicks in all the quadrants of the uterus. So usually baby kicks at only one quadrant, but if you get multi-quadrant kicks continuously occurring, hampering mother's sleep, and more than 10 in an hour or multiple, if it's occurring, then it could be a fetal hyperkinesia. Majority of them are usually because of, in a case of neonatal seizure, we do ask for them to rule out intrauterine seizures. Then you also ask history of drug intake, negative history of drug intake. So which drugs were you interested in for mother and which drugs for the fetus? Did you ask the drug history for mother or fetus or both?
So for the mother, like, in general, there was no history of any drug intake apart from the supplements required.
Yeah, so why, what does that indicate? Why did you ask that negative history of drug intake? Which drugs were you interested in, which could cause neonatal seizures?
So generally, and if the mother is on antidepressants like SSRIs, that can cause uh, fetal, like that can lead to
Mm.
neonatal seizures.
Yeah, SSRIs or antipsychotics. Their
So,
withdrawal, and so when they, if they are continuously taking during pregnancy and baby is getting those via placenta, and then suddenly if there is a withdrawal, even if the mother is taking any opioid prescription or without prescription drugs, if there's a withdrawal, then you can have this neonatal drug withdrawal, opioid withdrawal, you can have seizures. It can be a part of that thing. Then
so,
why did you ask the family history?
so there are a few, again, there are genetic syndromes which are associated with family history. Like the, mm, so there are two kinds of genetic epilepsy syndromes which present in the neonatal age group. One of them is the self-limiting variety, and the other is the epileptic encephalopathy with developmental impairment. So, if there is a positive family history, we can link towards that. And also, if there is a family history, then it goes more in the favor of channelopathies if there is no other cause found.
Yeah, so you have, there is something is known as self-limited neonatal epilepsy and self-limiting infantile epilepsy. Both of them can have positive family history. So both the children can have seizures, but the usual age of onset of those seizures is day 5 of life. So in earlier textbooks they used to be called as fifth day seizures.
Yes.
So yeah, you should ask those. Any history of epilepsy in neonatal age group or infantile age group, because the gene for both is same only. It is related to potassium channelopathy. So you should ask the history of seizures in family, both mother and father in the neonatal or infantile period.
Um, so
Yeah,
that
could you back
the
the video?
video. So when the baby was admitted with us for the second time with breakthrough seizures on day of life 21, these were the kind of seizures. Just a minute, sir.
Dr. Sandeep, you if you want to ask anything.
Yes, sir. So you want me to play the video again, sir?
Yeah. What I could appreciate over here is some myoclonic jerks of the left lower limb and some perioral movements, and the increased breathing, the diaphragmatic breathing was increased during the time. The only thing
Yes.
I'm trying to tell you this is because although we try to label any neonatal seizure based on what we see, as per ILA, only a focal seizure can be told by a clinician, that is a pediatrician or a neonatologist. Rest all seizures require a electrical correlate, electrographic correlate or a EEG correlate, and then only that paroxysmal event can be called a seizure. So all of which you described, the tonic posturing, the tonic convulsion, the myoclonic seizure, without a electrographic correlate, they will be paroxysmal events until proven otherwise. Only a
Okay.
focal seizure, which is seen by an expert clinician or pediatrician or neonatologist, can be called a seizure. That too a possible seizure, not a definite seizure. For definite seizure to be called, you need a electrographic correlate. I understand that it's very difficult in the setup in which we are working, but you still need to be aware of it.
Yes, sir. The new ILA classification. Yes, sir.
So I the classification also had experts from our subcontinent.
Yes,
So
sir.
there was representation of India also, and all of them came to this consensus that without EEG, the only seizure which you can tell that's a seizure categorically is a focal seizure. Without others cannot be told without EEG. That thing needs to be kept in mind. And another thing is never ever in neonate tell the seizure is generalized, because neonates don't have generalized seizures because of decreased myelination and the corpus callosum connectivity being poor. The most common seizure in neonate, apart from subtle seizures which we see in HIE, is multifocal clonic seizures. So neonates generally do not have generalized seizures. They are usually multifocal. They are never generalized. So all the classifications, if you see, there will never be a generalized seizure in a neonate. So that's what you should avoid when you are presenting a case of a neonatal seizure, because generalizability is not possible in a neonatal brain.
Okay, sir.
And another point I would like to make: whenever a neonate fails two medications, either phenobarbital or levetiracetam, or phenobarbital followed by levetiracetam, the rule is give trial of vitamins, that is pyridoxine, pyridoxal phosphate, folinic acid, and biotin. This should be a rule rather than an exception, because beyond two drugs, phenobarbital and levetiracetam or phenobarbital and phenytoin, other drugs usually won't help. So if they are resistant to two drugs, then usually they are not acute symptomatic seizures, like seizures because of meningitis or any intracranial infection or any metabolic abnormalities like hypoglycemia, hypocalcemia, and dyselectrolytemia. They are usually a genetic etiology of epilepsy in a child with normal MRI brain or normal neurosonogram. First of all, after failure of two drugs, the response should be adding these vitamins. Until your genetic test comes, you don't stop them. That is a practice we should all follow. Matlab, be going beyond two drugs in neonatal seizures without giving trial of vitamins is usually counterintuitive.
So I had some questions, Dr. Vinita. So first of all, do you know the grading of diagnostic certainty to diagnose a seizure? There is a grading, like what is a definitive seizure, what is a possible seizure, what is a probable seizure.
Yes, sir. So, according to grade recommendations, level 1 recommendation is by conventional EEG only. Amplitude integrated EEG, if you diagnose a seizure by amplitude integrated EEG, it is level 2A. Then, if a focal seizure or a tonic seizure is recognized by an experienced personnel, that is grade 2B, and the rest are beyond. Like automatisms are grade 3, if I remember correctly. I'm not sure. But for it to be a definite seizure, it has to be a conventional EEG, and by amplitude integrated EEG, it is a probable seizure.
So what are seizure mimics? Can you give me some examples of seizure mimics?
So one of the most common seizure mimics we see in the neonatal age group is jitteriness. So that is confused with myoclonus, but it has a higher frequency and the amplitude is the same in both directions. Like in myoclonus, the amplitude is higher in only one part of the movement, but in jitteriness, it is equal in both parts, and you can stop it once you calm the baby. Once you hold the baby, you can stop a tremor, jitteriness or tremor. And then there is hyperreflexia, which is basically an exaggerated startle reflex. uh, the baby will react to a loud sound or a painful stimulus. That will be an exaggerated startle reflex, which is also one of the seizure mimics which we see.
And in your examination, you had mentioned that the child was stuporous. So how do you label the child to have stupor? Or how do you decide on examination that the child is stuporous?
Uh, so the uh,
So to put it other way, what are the levels of alertness in a newborn? Whenever you are examining a newborn, what are the levels of alertness you usually see?
there is alert, then there is quiet alert, and there is arousable. So that is the stage of light sleep where you can easily arouse the baby. And
Okay. So those are actually neurobehavioral states. What you are telling me, they are the Bechtel's neurobehavioral states. What I'm asking is that if you want to assess the level of alertness, there is one goal-based grading for the level of alertness. Okay, and according to that, you can classify the child as having. I mean, the level of alertness can be classified as normal, or stuporous, or coma. And if the child is stuporous, again, it can be divided into mild, moderate, or severe stupor. Okay. So you need to look at two things. Which are those two things which you need to look for to decide the level of alertness? So one is the arousal response, and second is the quality and quantity of movements. Okay. So based on those two things only, you can label the child. Once you, I mean, when you are labeling the child as stupors, I mean, especially when you are presenting a neonatal case for your fellowship exam, also the examiners might be interested in knowing what level of stupor, and based on what you told that the child is actually having stupor.
okay, so
Okay. And then, what is the first line anti-seizure medication which you usually start in your unit?
phenobarbital.
Okay. And what does the evidence say?
The ILA released a couple of recommendations in 2023. This is one of the only evidence-based guidelines that phenobarbital should be used as a first-line anti-seizure medication in neonatal seizure, irrespective of the cause.
Okay. So as of now, I mean, by conventional, uh, we have used phenobarbital. So still, till date, also it remains the drug of choice. Uh, Earlier studies they had told that levetiracetam is inferior, but now of late there are many studies which are showing that the control with levetiracetam is also equally good. And what about the second line anti-seizure medications?
According to the same guidelines, they are consensus guidelines, not evidence-based guidelines. They recommend second-line anti-seizure medication as either phenytoin, levetiracetam, or lidocaine uh, to be given.
Okay. Yeah, so there's no certainty as to which one is preferred over the other, but I mean, it is based on the individual unit's preference. Okay, right.
Yeah,
And
I like to make one point over here, a clinical point which would help. So basically, although they are consensus guidelines, they are based on multiple studies which they have quoted as evidence. One of them is Neolev 2 trial, which is a randomized controlled trial of phenobarbital versus levetiracetam, in which they proved that phenobarbital is more effective than levetiracetam in seizure control, but phenobarbital neonates had more sedation and other side effects, but not life-threatening ones. So efficacy-wise, phenobarbital is better than levetiracetam. Retrospective studies and control studies have shown that levetiracetam at a higher dose, that is 40 to 60 milligram per kg, is as effective as phenobarbital 20 milligram per kg, but with lower side effect profile. So that's why they quote in a way that levetiracetam is may be equally effective as compared to phenobarbital as a higher dose and have less side effects like that they are trying to quote. But whatever said and done, efficacy wise, phenobarbital is better than levetiracetam. So based on the unit's preference, anyone can be used. We use phenobarbital at CMC Vellore, and majority of units in India are still using phenobarbital only. AIMS Delhi and Mumbai people also. Second, about second line drug, as you told, it could be anything. If you use phenobarbital, you can use levetiracetam, phenytoin, lidocaine. One of the clinical clue is if you have something which is known as migrating focal seizures. That means one of the time it is right upper limb, then it's left upper limb, then third time again right, then starts with right, goes to left. If you have migrating focal seizures, they are usually suggestive of channelopathy. So in that, you have to use phenytoin as your second line agent or even first line agent. If you have a migrating focal seizure, use phenytoin as your first line or second line agent. And then if you have a seizure control, then convert it to oral carbamazepine because they are usually sodium channelopathies who have migrating focal seizures. So this is the clinical clue which we use. So if we get a history of migrating focal seizures, we use phenytoin as either first line or second line. But however, if you are not sure of the etiology or if the etiology is acute symptomatic because of a HIE or a meningitis or any metabolic condition like dyslipidemia, then you treat those things. But HIE and all, you can use phenobarbital followed by levetiracetam. But phenytoin has to be specifically used in neonates who are having migrating focal seizures. So that needs to be kept in mind. So whenever you have migrating focal seizures, phenytoin is the drug of choice because clinically they would be a channelopathy. So that is important.
Okay, sir.
This burst suppression also you don't have, no? Was you told second EG was showing burst suppression?
Yes, sir. No, I don't have the image of the graph. I don't have it.
Sure. Yes, Dr. Sandeep, you were telling something. Sorry.
No, I was just asking, I mean, whether the gene analysis report is yet awaited or it has.
Sir, actually, we have gotten a report, but it is, I mean, it shows a mutation with the ALDH71 gene, but they have mentioned it as a insignificant variant, so they can't really be sure whether that it's not pathogenic. So,
No, no, you just show the report. I'll let you know.
yes, sir.
They can show. Yeah, yeah. So you see over here, it's exon 17 and it's a missense mutation, homozygous autosomal recessive. So basically, the geneticist over there, if they get a missense mutation, they don't report it as pathogenic variant until and unless they get clinical clues or investigative clues, or they get a parental study. Okay, so if you tell them clinically that this child has seizures which are not responsive to phenobarbital and levetiracetam, if you tell them that seizures recur after stopping pyridoxine, and if you tell them that seizures are responsive to still pyridoxine, then they will change this to likely pathogenic. And if they
Okay.
do a parental study, like parents, and if both parents are carriers, then they'll change it to pathogenic. So a
Okay.
VUS does not mean that the genetic report does not match the phenotype. This matches the phenotype over here. So this
Okay.
report should be changed to likely pathogenic over here, but you have to talk to the genetics team and then only they will do it.
Okay, sir.
Otherwise, if it is a nonsense mutation or it's a termination mutation, then they will tell it likely pathogenic directly because
Okay.
nonsense mutations are more likely to be pathogenic than non-pathogenic. So that's why this uncertain significance is there. You can see that PM2, PP3, which is written. Okay, so these are all ACMG guidelines, American College of Medical Genetics and Genomics guidelines, which tell them to report like this because they don't have the entire picture with them. But once you give them a clinical investigative picture, they'll change it to likely pathogenic. And once the parental studies are done, then this will change to pathogenic, the same report. So it's just
Okay.
that we have to follow up with the genetics team and then they'll change it. Otherwise,
Okay.
90% of the reports which you will be seeing will be in VUS only because majority of mutations are missense mutations, which we get in daily life. So this does fit the phenotype, actually.
Yes, sir. So the only thing clinically, the baby did not have seem to show any developmental impairment. I mean,
No, so they will not show. It
at
will take time. If you don't treat them, then only they will show developmental impairment.
so
If
the
the
baby
seizures are
is
continuing,
controlled. No, sir. I mean, on follow up, there has been no seizures till now. It has been a
because
month
the
since
child
we.
is because the child is on pyridoxine, no?
Yes, sir.
That's why he's not having seizures. That's why pyridoxine is a precision medicine for ALDH7A1 related epilepsy. You can stop all other medicines and still you will have good seizure response. The only thing is you should the pyridoxine dose should be 15 to 18 milligram per kg per day. And when you are getting the EEG done, actually you have to do a EEG pyridoxine trial. So anyone who has had two seizures which are refractory to two drugs like phenobarbital and levetiracetam, what you do is you attach the EEG and give IV pyridoxine 100 milligram in 100 ml NS infusion over 2 hours. So it's a prolonged EEG which you should be doing. So before pyridoxine, you have a EEG which shows some changes, and after pyridoxine, that changes would disappear or they would improve. So that's what we call pyridoxine responsiveness. And once you have pyridoxine responsiveness, that's when you can say that this is a pyridoxine dependent epilepsy. Okay. So there are multiple pyridoxine dependent epilepsies. ALDH7A1 is one of them. Another one is PNPO mutation, which is pyridoxal 5-phosphate dependent epilepsies, but they could also be pyridoxine responsive. They could also partially respond to pyridoxine. Then there is something that is known as folinic acid responsive epilepsy because of FOLR mutation. That also is pyridoxine responsive epilepsy. Then KCNQ2, SCN2A, all these are pyridoxine responsive. So there would be some response to pyridoxine, but this ALDH7A1 usually has complete response. So the bus suppression would become a normal background EEG in front of you. It's that miraculous, the response in ALDH7A1. So, and as soon as you stop pyridoxine, they'll start seizing again. This is also a test of clinical readiness. So if you don't have a EEG, so what we follow is give phenobarbital, levetiracetam, no response, give pyridoxine, pyridoxal phosphate, folinic acid, biotin, and then start tapering one drug. And as soon as you taper, if you get a seizure again, you know that that is the drug which is causing the seizure control. So let's say you tapered pyridoxine and the seizure started, you know it's a pyridoxine dependent epilepsy, something like that. If you don't have EEG, this could be done, which happened coincidentally in your case also. You stop pyridoxine biotin, again the seizures occurred.
Yes, sir.
So this is a likely pathogenic mutation. The only thing is with pyridoxine, you have to always add folinic acid because around 30% of pyridoxine dependent epilepsies may continue to have seizures on pyridoxine alone, and they may require folinic acid because these children have decreased cerebral folate. So you might have to add folinic acid, and some of them may require arginine also in a lysine restricted diet. But lysine restricted diet is very difficult to give, but arginine supplementation can be done in cases refractory to pyridoxine and folinic acid. So it's a spectrum. The good ones respond only to pyridoxine, but the moderate ones require pyridoxine and folinic acid, and the severe ones require pyridoxine, folinic acid, and arginine supplementation.
Okay, sir.
But it's a treatable epilepsy. So any epilepsy less than 18 months, I will not even say neonate, any child less than 18 months who has unexplained epilepsy, that is unexplained by your blood investigations, unexplained by EEG, unexplained by MRI, you should always give trial of these four vitamins: pyridoxine, pyridoxal phosphate, folinic acid, and biotin. They are easily available in any part of the country. So this should be given and genetic test should be sent, and then further investigations need to be carried out based on that. But these four are the treatable conditions and should always be treated after ruling out the common causes which we see day in and day out.
And, so, what would you like to counsel the parents? I mean, ultimately, the parents at the end of the day, they are interested with how the child do as he grows, or what would be the long-term outcome. So, how do you want to counsel the parents?
Um, so as the patient baby is already on pyridoxine and there have been no further seizures, there is likely to be a good prognosis if the baby is continued on pyridoxine supplementation. but we'll have to keep monitoring for any developmental impairment as we go.
What do you want to do when the child comes for follow-up? How do you assess the development?
So I would like to look for all the like gross motor, fine motor, and social milestones. And there are assessment tools available. I mean, so there is a neurobehavioral assessment scale which you can implement, or if that becomes too extensive, you can just check for milestones using the random developmental scale, like basically whether the baby is reaching milestones or not.
And what is the plan about the anti-seizure medications?
So now that we have a cause that this is pyridoxine dependent and pyridoxine responsive, we can gradually taper the rest of the seizure medication, starting from the one which we started last. So in this baby, we had started topiramate in towards the end. So we'll try to taper it over 2 weeks and then go on tapering till we reach phenobarbital and gradually taper phenobarbital also and continue with pyridoxine. And as such, the rest of the substance, folinic acid too.
Yeah, so you should continue pyridoxine and folinic acid for this child and then gradually taper the other anti-seizure medications.
Any other question from, I think, both expert, Sandeep and Dr. Sri?
Just
Hello,
one question.
can you hear me?
I mean, a general question. What percentage of neonatal seizures uh, can be diagnosed just by clinical observation? I mean, if you rely only on the clinical observation, what is the percentage of seizures you are likely to miss?
So almost like 60 to 80% of seizures are electrographic only seizures.
Yeah.
So which do not have any clinical manifestation. So that is why if we have a high risk, like if a baby is at higher risk for development of seizures, should be ideally should have to undergo conventional EEG for definitive diagnosis.
Okay. And what is the sensitivity of amplitude integrated EEG?
So I don't remember the exact value, but it has a high sensitivity, but it is not specific. So there are less false positives. So we can generally rule out that the baby does not have a seizure if an amplitude integrated EEG does not show seizure seizure activity. But I don't know the exact value of sensitivity.
So, given a choice, which one of the two is better? Amplitude EEG or conventional EEG?
But ideally speaking, conventional EEG should be done. But if we have a resource limited in our setting, if we can train a few people for amplitude integrated EEG, we'll at least have a better understanding of which the baby, especially at risk, we would not require expertise to diagnose an electrographic seizure. So,
And in amplitude integrated EEG, if the child is having a seizure, how do you recognize that?
so basically, there is a minimum threshold for the minimum voltage and the maximum voltage. Based on that, uh, the minimum voltage will be that is
There
what
is
I don't.
overshoot. I mean, you'll see areas where the minimum voltage also it overshoots. Okay, you will see some spikes at the lower this thing voltage. Okay. So, do you have any experience? I mean, have you ever used amplitude integrated EEG in your user?
Uh, no, sir. No, sir. We ask for conventional EEG only, but
Okay.
and we don't do it for all babies. It is just the babies who do present with seizures for confirmation.
Okay.
Like, there is no monitoring as such using AIEG.
So
Okay.
your
So,
institute
other
has a conventional EEG?
Sorry, sir.
Your institute has a conventional EEG available?
Uh, I mean, we can order for a conventional EEG. Yes, sir.
And can it be ordered for continuous recording also 24 hours and all? Do you have technician or to attach the electrodes and all?
So
Reading can be done by a neurologist or a neonatologist trained,
we don't
but
have an in-house technician as of now, and we have not done a 24-hour continuous EEG monitoring. I mean, not to my knowledge, till I have
okay,
from the
so
time I have joined. So,
yeah, it's not that easily available. Agreed. Yeah, but yeah, you should do for at least a prolonged record and pyridoxine trial. You should do. The only thing is when you give IV pyridoxine, they are prone to apnea and all. So at that time, you need to keep the ventilator kit ready in front of you. But if you give it slowly over 2 hours, majority of them do tolerate them well. And if they are really pyridoxine responsive, then you will get a very good response in EEG also. So that could be tried if possible. Another clinical clue which I would like to highlight is if it is a male child, always look for an abnormal genitalia. So if you have abnormal genitalia in a male child, they would be usually ARX gene mutation. They will have corpus callosum dysgenesis, cleft lip, cleft palate, and abnormal genitalia. So midline defects. So they will also have severe neonatal epilepsy. And if it's a female child with neonatal epilepsy or infantile epilepsy, do a CT scan to look for calcifications or cysts, interhemispheric cysts in the CT scan. That could be a clinical clue for Aicardi syndrome. So, based on the sex of the baby, also some of the neonatal seizures can have a clinical and a genetic diagnosis just based on certain investigations which we see. So, always comment on genitalia in a case of neonatal seizure and look for midline abnormalities and comment on that in a male child. And in female child, make sure that you look for Aicardi syndrome cases. They are commonly seen, rare but common.
okay.
Anything, Sandeep, Sridhar?
Sir.
I think it was a nice presentation, Vinita, and nicely give the all the answer. Anything from the delegates, anything want to ask, and also, ma'am, Sheila, madam, if you want to share anything regarding the neonatal seizure.
Uh, Sridhar, I just wanted to know what is the long-term prognosis of this pyridoxine dependency seizures, and is it lifelong then to be continued?
Yeah, the pyridoxine has to be continued lifelong. And as I told, it's a spectrum. The mild and moderate ones respond very well to pyridoxine, maybe with addition of folinic acid plus minus arginine. The severe ones are DEE phenotypes, that means developmental and epileptic encephalopathy phenotypes. So in them, despite giving pyridoxine, pyridoxal phosphate, folinic acid, and arginine, they may have some developmental lag. But 90 to 95% of pyridoxine dependent epilepsies do well developmentally. Overall spectrum, they do well, but they will require lifelong medications. And some of them are late onset cases also. So some of them may start epilepsy onset around 1 year of age and then can have. So in our unit, although textbook says 18 months till 3 years of age, if anyone comes with unexplained epilepsy, we do a pyridoxine trial EEG on them.
Okay.
So there are some late onset cases also in the literature, and we have seen quite a few. But overall, if they ask, it's a good, if they have responded in neonatal period, then they do have good prognosis developmentally. Mild cognitive deficits and all those things may persist, but yeah, they will do good well in life. But yeah, they will require frequent monitoring. And in 18 months, they'll require Baileys.
Okay. One more question related to abnormal genitalia that, like most many of them, like this is one child, one baby whom I've been seeing.
Ma'am, sorry, your voice is breaking, ma'am.
Is
Sorry,
the
ma'am.
bilateral cryptorchidism with micropenis,
Sheila, madam, your voice is breaking,
consanguinity,
ma'am.
small head. I mean, not so much of it. So, okay. Maybe we'll take it later if I can, because I'm at a place where I cannot shift to. Hello.
Okay.
Hello, yes, ma'am.
Yeah. Now just clear, ma'am. You can ask
Is
again,
it?
ma'am. Still breaking, ma'am.
This
Still.
was still it's creaking, no?
Yes,
Let me
ma'am.
just check my yeah. Or maybe we can take it later. It's some other venue. I'll discuss it out. Let's go because we are, I think, overshooting time also. Vishal.
Yeah. No, I mean, we have time, ma'am. 5 to 10 minutes more. You can ask if we have better network. If
Yeah, but connectivity
okay,
is
okay.
I'm through mobile.
Uh,
Uh, Signals are creating a
that's fine. Anything from Kunal or any other participant want to ask question? You can directly unmute and can ask. Sita, I have one question for us actually, for me actually. When you give the phenobarbital in the preterm baby, do we have any long-term, consequences for that one? Of course, we are giving for the seizures, but what
This
happening
all
with the
all
myelination?
these things of apoptosis and neurodevelopment which have been created, now they are all animal models by and far.
Oh,
Okay. When
okay,
phenobarbital is used for neonatal seizures and the seizures respond and the etiology is corrected, they all do well. So basically, see, we are in India. If you have a child with, let's say, mild HIE, or when we use phenobarbital, usually the seizures in neonate are usually because of hypoglycemia or hypocalcemia or dyslipidemia or sepsis or meningitis. So once those things are taken care of, they usually do well. Their seizures get controlled, and even on discharge, they don't require any long-term anti-seizure medications. Okay, the ones who are having HIE, if you use phenobarbital, mild HIE also, if on discharge they are neurologically normal, you don't give phenobarbital at discharge. The only moderate to severe HIE is you give phenobarbital and assess them at 3 months of age for neurological status examination. If the neurological status is 3 months is normal, again you stop phenobarbital. So when you give phenobarbital at this dose, the maintenance dose which we use is 5 to 8 milligram per kg per day. See, because of HIE, if there is a damage to the language network or if there is a damage to the visual network, they will have deficits because of that. But phenobarbital leading to these deficits, it's not possible. Whatever studies are being done, they have given phenobarbital in animals, and then they have seen those animals. They have done the biopsy of the brain and shown that okay, brain is showing apoptosis, brain is showing necrosis, the circuits are getting dislodged and all those things. But this is not a human study. Humans, we are not going to do biopsy and all those things. We just see them clinically. So because of the insult per se, they will have some cognitive deficits and neurodevelopmental outcomes. Phenobarbital leading to it is just an association; it's not a causation. So I
yeah,
think
but like for example in the preterm also, like I'm not talking about
yeah,
the
in a
HI
preterm
or the I
also,
particularly, yeah, okay,
it's a safe drug. Take it from me. I have seen the neonates who come to high risk clinic and neonatal epilepsy clinic because the only thing which leads to their neurodevelopmental and cognitive sequelae is the insult which caused the scar in the brain or any MRI insult which it is causing the defects. It's not the drugs which are causing it. They are tolerating the drugs very well. Okay, so it's
great,
so
great.
association is there, but it's not the causation. Phenobarbital does not cause long-term neurocognitive or neurodevelopmental effects. It's the disease which led us to use phenobarbital from there. That disease sequelae is causing the problems in the children and infants, preterm,
Okay,
term, any age group. So if you
sure.
have
Thank you.
periventricular leukomalacia because of prematurity, that periventricular leukomalacia will cause problems, neurodevelopmental problems, spastic
Yeah,
dipalesis,
yeah.
nuclear nonsense and all.
Yeah,
Phenobarbital is
but
not going to cause.
even though there's no any abnormality, I'm just because now era is a perinatal viability, so we are just saving from 22 weeker to 26 weeker, and if you see the graph which we are in the Gujarat people are saving, sometimes we have to give the guardian not for the convulsion, also sometimes the sedation, So that's why we little bit worry, and Sweden, one of the finest in Japan, they are giving guardian regularly. So I have same patient with them, their people, and they are also say same thing. So it is not about the PV or anything, but that's why I'm asking particularly that does this drug affect the things or not? Of course, we know that if it is associated with IVH, PVL definitely affects. Even the prematurity is also leads to the neurodevelopment. do we have any study which we can say that the phenobarbital can affect the brain? That's my
No,
question. So
studies are
till now we
association.
do
They are
not
not
have.
positive.
Am I right? Yeah. So
Yes.
that's the thing. Yeah.
So they are positive. They are
Anything
not
from
positive.
yeah, yeah. Okay, that's great. Anything from Sachin, sir? I think if you and after that we can end the session. Like and nothing. Sachin, sir.
I think it was a very good session, a very good discussion, and thank you, Dr. Sridhar and Dr. Tilwani. Nice learning for all the fellows who are appearing for the exams and on a routine basis how to approach neonatal seizures. Thank you very much, Dr. Sridhar, for your expert comments. And one thing what I think Vishal was talking about is how safe is phenobarb when we are talking about ELBW babies near 24, 25 weeker. And we had seen some data about Japan, where they have survival of 20 to 23 weeker also in a very good way. And they have been using phenobarbital for the prevention of
Bottom
As a
line,
IVH
routine.
the
As a
first week
routine.
of
Yeah.
life.
bottom line is it's safe. We have to use if
Yeah,
it is
so they have been
required. We
using
have to
that,
use.
and
But
what I was seeing is that the overall long-term outcomes of the result of Japan versus the Iowa centers in US, which has one of the best neonatal outcomes in extremely small babies, they have done quite far better. So we do not have a lot of evidence that phenobarbital is doing any damage to the brain per se, but as a prophylaxis, the still the consensus is very much more institutional rather than a very clear-cut guideline.
I don't believe in phenobarbital prophylaxis for sure. That we are not practicing. I am not aware. We are not practicing in CMC at
Yeah,
least.
but there
If
are
you have
some
a
units who are doing a phenobarb
if you have a
prophylaxis,
electrographic
and
seizure, if you have electrographic seizure in a neonate because of prematurity or HI,
yeah,
then we do use phenobarbital, but not for prophylaxis because I don't
yeah,
think
yeah.
there is evidence
It is the
for.
only center in Japan which is doing there. Only the Japanese do it their way. None of the other Western world countries are doing phenobarbital on a prophylactic basis just for prevention of IVH. And we do not have any good meta-analysis also to support that. So we also do not use it. And most of the units do not use phenobarbital as a prophylaxis.
Well, yeah,
yeah,
professional.
we use the
Lot of
fentanyl for
people
the
think we
sedation,
use
but not
levetiracetam.
anticonvulsants.
I don't know why, but the practice is changing nowadays. Nowadays, everyone calls levetiracetam de diya ab kya dena hai? I'm like, why phenobarbital is not given? Because well, yeah,
Yeah,
maybe
yeah.
they are better doing better marketing than phenobarbital. That's why people are
Yeah,
taking
but see,
levetiracetam.
what we are seeing is that most of the pediatricians and the level 2 centers, they're not using phenobarbital as the first line of anti-epileptic drug. They are using
Yeah.
levetiracetam because they feel that phenobarbital will lead to some sedation, respiratory depression. You might need to intubate the child. And what I'm seeing is now the seizure control, which was there very good since so many years with the advent of levetiracetam and now being actively promoted, marketed everywhere. Most of the, I think almost 50-70% of the neonatologists or pediatricians in the periphery have started using levetiracetam as the first line anti-epileptic.
Because that's what their information they are informed based on the not based on the evidence. They are informed based on the companies which are showing them that okay it's
Yeah,
better.
yes, we do not.
Because when you
Yeah,
show the graphs, you show the superior. You don't show the efficacy graph. You show the graph that they are both equally effective. You don't show the dose. The dose is 40 milligram per kg for levetiracetam and 20 milligram per kg for phenobarbital. We just see the two lines and the p value. But the efficacy
yeah,
of phenobarbital as an anti-seizure medication is better than levetiracetam.
yeah,
Sir,
yeah.
So
No, no, no.
information.
definition of breakthrough. One of the chat box has a question.
So,
Hello.
yeah,
Yeah,
yes,
Dr.
madam.
Pranjal, you can ask the question.
Sir, there's a question. What is the definition of breakthrough seizure?
So there are two terms in epileptology: breakthrough seizures and withdrawal seizures. So, suppose the child is on phenobarbital maintenance dose, and on that he was seizure free for let's say 5 to 7 days, and on that maintenance dose with good what do you call compliance. If you have another seizure, that's what you call breakthrough seizure. That means you are having seizure despite good compliance with anti-seizure medication. And withdrawal seizure means the drug has been withdrawn. You have tapered the drug, or the drug was not taken by the parents, and then you have seizure that is known as withdrawal seizures. So you have
Oh,
breakthrough seizures despite being on drug with good compliance, and withdrawal seizures is after withdrawal of drug. These are the two terms which we commonly use in epileptology.
okay, sir. Thank you, sir. Thank you.
Thank you so much, everyone. Thank you, Vinita, for the excellent case presentation. Thank you, Dr. Sachin. Thank you so much, Dr. Sridhar and Dr. Sandeep Tilwani, for the excellent discussion. And it was really an interesting case was also interesting, and the discussion was also very nice. So thank you all the experts for the wonderful discussion. Thank you, Sheila ma'am, for being there, and Dr. Sachin for being there. Thank you, Dr. Vishal, and thank you to ClearNet for the seamless experience. With due permission, if there are no questions, we can end the session. Thank you.
Thank you. Thank you all.
Thank you, sir.
You.
Thank you. Yeah. Ritu, yeah, we can end.
Thank you. Thank you so much, sir, for extending us the opportunity to host the session today. I hope you had a seamless experience. So, with all these, if there are no further questions, we are signing off for today and looking forward to host you again soon. Goodbye, everyone. Take care. Thank you.